from the American Academy of Pediatrics.
Diagnosing abusive head trauma is complex and challenging because of the clinical, social, and legal implications.
A new technical report from the AAP offers a comprehensive review of the evidence-based literature on these injuries.
We as child abuse pediatricians don't relish coming to this diagnosis at all. It is down the road so much effort on our parts. You could even argue that we constantly try and fight that bias against coming to this diagnosis. And so what we try and do is we be as systematic as we possibly can all the way through.
Plus, a new article examines diagnostic delays in pediatric and adolescent adnexal torsion.
It's something that can be easily missed, so keeping it on the forefront of your mind in any female patient that presents to the emergency room with these symptoms is critical.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well.
Let's start today's episode with a discussion about abusive head trauma in infants and children.
David, we've talked about how difficult it can be to diagnose child abuse. One factor that comes up again and again is head trauma in infants and young children.
So when you see head trauma, Joanna, do you feel comfortable determining if it's accidental or abuse? I can find it pretty challenging.
Honestly, if it's right after birth and the baby has always been in the hospital, a lot of times I can point to the birth itself to explain things like skeletal fractures and subdural bleeds. So I don't have a lot of trouble there. It's after the baby has gone home. Did they have those things from the time they delivered? How do we know?
You know, the truth is that's a nuanced and complex diagnosis to make, so we need continued and comprehensive guidance on this. We have to sit in our discomfort, learn from it, and use evidence-based medicine to get through it.
That's why I'm relieved that the AAP is releasing a technical report titled Abusive Head Trauma in Infants and Children. And today we get to talk with the lead author, Dr. Sandeep Narang.
Dr. Narang is a professor of pediatrics at the Medical College of Wisconsin and attends at Children's Wisconsin. He specializes in child abuse pediatrics and serves as chief in the section of child advocacy and protection services at Children's Wisconsin. Sandeep, welcome.
Oh, thank you so much, Joanna and David. I'm glad to be here and appreciate the opportunity to talk about this important topic.
Thank you so much for joining us. And let's start with definitions. What do we mean when we say abusive head trauma?
So that's a great question, Joanna. It's something that I think we have been a little bit varied in past, even in our way we have termed this entity. I think it's been commonly known as shaken baby syndrome in the past. And in 2009, I think the American Academy of Pediatrics made the wise decision of using a more encompassing term and definition of abusive head trauma. The term abusive head trauma is probably best defined, as we outline in the technical report, as that is inflicted injury to the head or the contents within the head in a child less than 5 years of age, and that can occur by either blunt mechanism or shaking.
And do we know the extent of this diagnosis in terms of how many children are affected?
We have just estimates, annual estimates in children less than 1 and even going into less than 3. But we do know from the literature that those estimates are grossly underestimated. The current best estimate that we have is probably about 25 to 35 infants less than 1 year old per 100,000 children in the United States are affected by this disease.
You know, Joanna sees newborns and I see children at all ages. Is there a specific age where the risk tends to peak?
It definitely has been shown to peak in probably around the 4 to 6 month time frame, but can extend throughout the first year of infancy. But those tend to be the peaking time frames, and those tend to probably be just a little bit after that period of colicky crying time frame reaches its peak as well.
And do we know more about the demographics of these infants? Who is most at risk?
Wow. It's a difficult question to answer. I think One of the important aspects of this technical report has been to identify sort of the disparities in what the literature has identified in our current reporting about abusive head trauma. The literature has been confounded by disparities based upon certain racial populations being overrepresented in this disease entity. And this report acknowledges that. And so what I would say is that there are certain components of this disease that can be identified in terms of factors that can place a child more at risk, but definitely racial confounders, socioeconomic confounders in the literature do exist.
So how should we go about taking a history if we suspect abusive head trauma? And are there particular red flags we should be looking for?
Wow, that's a great question, David. And I would state for, our general pediatric providers out there who have a heavy clinical burden, limited time frames, to acknowledge upfront that this disease entity is going to take a little bit more time because the history is so important to tease out. Certain historical components have been associated to be more strongly associated with the abusive head trauma diagnosis. And those red flags include a changing history for the occurrence of trauma. That's been a little bit nuanced because what we mean by change hasn't been well identified in the literature. Does a fall in the kitchen versus a fall in the bedroom constitute a change? Probably not. But what we mean is a substantive change in the occurrence of trauma from something like, there's no explanation for this traumatic finding, to now all of a sudden I have an accidental explanation. So that's one thing. Obviously, a delay in seeking medical attention and care for obvious concerning medical symptoms has been an associated finding. And then obviously the absence of any trauma history for obvious traumatic findings has been an associated one that has been a cornerstone going back decades in child maltreatment.
As you're talking, it does seem like this is just a really difficult diagnosis to make based on history. When do we call in a child abuse pediatrician to help consult on these cases?
Joanna, I would say my guidance to any pediatric provider is, if you are unsure, given the gravity of this diagnosis, go ahead and make that call. Child abuse pediatricians welcome the opportunity for a conversation and discussion because of the complexity of this diagnosis. We recognize that.
And in particular, when infants have a neurologic concern, some injury or distress, I know how difficult it can be on exam to pinpoint what that is. So how might a neurologic presentation of abusive head trauma look in an infant or young child?
That is a very, very difficult thing for us, as much as we pride ourselves as clinicians to be able to sensitively identify. It is just so varied. The neurologic presentation of an abusive head trauma child can be as simple as a child that's being irritable or even sometimes looking clinically well, to a child that clearly appears neurologically abnormal to us, that may be having a limpness, an altered mental status, or even seizure-like movements. Those are clear, and we as medical providers can be clear that something's neurologically wrong. But it's to know that the child with abusive head trauma can present on the other end of the spectrum, that we need to remain vigilant for it, that although the child may clinically appear well and may actually even be slightly irritable or something like that, that we still need to be thinking about it, is something I would readily impart to our pediatric providers.
And beyond the neurological exam, are there other physical exam cues we should also be looking for?
Yes, I think the technical report aids pediatric providers in summarizing some of those findings, a lot of those findings, and what the evidence-based medical literature tells us. Some of those findings include bruising as one of those key sentinel findings, especially in vulnerable young infants and children in this age group. Bruising is a sentinel finding that's common in this diagnosis, and bruising in certain locations, the literature has shown us to be much more strongly associated with it. a wonderful study by Dr. Pierce, multi-center study throughout the country. I helped differentiate bruising locations in accidents versus abuse. Some of those bruising locations include the ear, the neck, the soft fleshy cheek, the soft torso, and even, other locations like the angle of the jaw, the subconjunctiva, things like that. But bruising in certain locations can be one medical finding that clearly points us to it on our physical exam. Other physical findings that are not readily apparent on the outward physical exam, but can be done through simple x-rays, can include fractures in certain locations. Rib fractures are a high and strong associated finding with this diagnosis, and certain other long bone fractures as well, things known as classic metaphyseal lesions, which we may not have heard of and since we've gotten out of residency. But classic metaphyseal lesions are another one. So this technical reports aids the pediatric provider in identifying those physical findings, both on our exam as well as on radiologic studies, that can be markers for this diagnosis.
And in speaking of radiologic studies, are there certain studies that you should get no matter what if you suspect abusive head trauma?
Absolutely. So if a child is presenting, or at least has a historical information of being neurologically abnormal, I would say it's worthwhile to do the first line neuroimaging, which is a head CT still. We haven't quite gotten to the point of appropriate sensitivity and specificity with our fast MRIs. So first line is still a head CT, and I would recommend that for any child that has either historical or current symptoms of neurologic abnormality or findings of trauma about the head, like bruising about the head. And then always get a skeletal survey in a child less than 2 years old.
What about ophthalmology exam?
Absolutely, David. So that is probably the most specific finding that points to this diagnosis, is a certain pattern of retinal hemorrhages that we are well aware of as pediatric providers. That pattern has been identified in the medical literature to be multi-layered in the retina, and the retinal hemorrhage is extending all the way out to the periphery of the retina, and often in both eyes, but can be one eye. So ophthalmologic exam is a key helpful tool. You don't need to do, though, the ophthalmologic exam necessarily if there is no intracranial hemorrhage. That is something that the literature has borne out, that your likelihood of having retinal hemorrhages in the absence of having some intracranial hemorrhage is extremely low. But if you definitely have any sort of intracranial hemorrhage, whether it be a subdural classically, subarachnoid even, then you should definitely get that ophthalmologic exam as early as possible, because within 48 to 72 hours, some of those retinal hemorrhages can vastly dissipate.
I think we're all afraid to some extent of asserting that there has been child abuse when in fact there has not been. Are there ways we can minimize the risks of misdiagnosis?
We as child abuse pediatricians don't relish coming to this diagnosis at all. It is down the road so much effort on our parts. You could even argue that we constantly try and fight that bias against coming to this diagnosis. And so what we try and do is we be as systematic as we possibly can all the way through. So you take the detailed history each and every single time. You do the detailed physical examination of skin finding each and every single time. And you have the uniform, standardized laboratory and imaging approach to each and every single child. So we don't allow those subconscious biases, which the literature has shown us can infect us, to come through. And those are: do your skeletal survey each and every single time. Do your first line neuroimaging when indicated each and every single time. Get the standard set of labs to rule out bleeding disorder, to go ahead and look for potential bone disease as well when fractures are present. Do those standard evaluations each and every single time so you don't allow these subjective biases to infect the diagnosis.
And would you say that that's the best approach overall for combating health equity concerns with this diagnosis, or is there anything else we can do along those lines as well?
Well, I think that's definitely one big thing we should definitely utilize. It's not the only thing. There are so many other things we need to be cognizant of. I would strongly recommend each and every single provider be educated on implicit bias. And so those are things that we need to be aware of each and every single time. But having the standardized algorithmic approach will help us minimize to a great degree this problem of the inequities in approaching this diagnosis.
And once we make this diagnosis, how do we treat these patients?
I think part of it, obviously, we need our subspecialty colleagues, because obviously the vast majority of these infants have significant intracranial findings and injuries like subdural hemorrhages and even sometimes more significant brain injury. We are reliant on our subspecialty critical care and neurosurgical colleagues to help us manage these patients. So if we find these things, getting them to those higher levels of care where these great subspecialty colleagues are available to assist, that's a key point for our pediatric providers in the community to know, is to make sure we get them to the appropriate level of care where these additional subspecialties can weigh in, pediatric ophthalmology as well, because we need those additional tools for evaluation. That's what I would say in terms of managing it, is to make sure we take them to the appropriate level of care and then being reliant upon our additional subspecialists to work as a team in managing these, depending upon the way the child presents.
I remember in residency, we did this period of purple crying intervention. Are interventions like those designed to prevent these cases the most effective way to keep these situations from occurring, or are there other ways?
I would say there is a strong evidence base, and we cover this in the technical report, for showing significant value to some of these prevention programs like period of purple crying. They definitely, undoubtedly, enhance our parents' knowledge about the dangers of crying, and they definitely actually increase our parents' awareness of the dangers of crying, and they can even to some degree modify parents' behaviors in response to crying, and that's significant value for these prevention programs. But what hasn't been shown so far, at least repeatedly, in at least some prevention programs like the period of purple crying, is its impact on actual reduction of the incidence rates of abusive head trauma. I think there's where there's an opportunity for a lot of other prevention programs to help assist to kind of mitigate some of the, social stressors that families experience that can provide a circumstance that can lead to this diagnosis. So things like Family Paid Leave Act has been definitely one public policy that has been shown to impact abusive head trauma rates. And so things like that, I think, are additional prevention programs that we should be looking at, exploring in ways to kind of temper the social distress that the family is experiencing in these momentary experiences that can lead to this diagnosis.
I want our listeners to read this paper because it is a truly comprehensive report. Are you able to give us a few major takeaways that they can listen to and walk away with from this podcast?
So I was fortunate enough to work with so many experts, subject matter experts, on the various aspects of this diagnosis in this report. Our neurosurgical colleagues, pathology colleagues, even a biomechanical engineer who's well reputed in the country. And so we knew the comprehensive nature of the scientific information would warrant takeaway points. And we put them at the end of each sort of relevant subsection. I think some important ones for pediatric providers to think about is that remaining vigilant for this diagnosis requires taking detailed history that can really help us at the very outset in differentiating whether accidents are plausible and even sometimes whether no trauma history is present, and therefore then we should really be on concern when traumatic findings are present. And again, like we had mentioned earlier in our conversation, certain physical findings, like bruising in certain regions, can be our physical clues as medical providers to be alert for the diagnosis. And then to be aware, actually, that, again, like we have already talked about, that there are disparities in the literature that warrant our systematic approach to this diagnosis. And then finally, that prevention programs do exist. We should be implementing them sort of almost uniformly in hospital settings and even considering employing them in community hospital settings. but look at even broader prevention programs like we had just mentioned on the Family Paid Leave Act, as well as other things that can really start mitigating this horrible disease upstream.
Well, I want to thank you for those takeaways. Dr. Sandeep Narang, thank you for sharing this work with us today.
It's absolutely my pleasure. Thank you so much for having me here, Joanna and David. I really appreciate the opportunity.
To read the technical report, Abusive Head Trauma, go to aap.org/podcast.
Coming up, we'll look at delays in diagnosing children and adolescents with adnexal torsion. I remember being a resident in the emergency room in Los Angeles, and when adolescent girls would come in with abdominal pain as the chief complaint, it was always hard to know what the workup would be.
It is. There are so many conditions that can cause abdominal pain. In adolescent girls, I know many in urgent care or emergency settings will automatically send a pregnancy test, but then do you do imaging afterwards? It can be really hard to say.
Yes, but there are very serious pediatric conditions that can be related to abdominal pain. One of them is adnexal torsion. It's not that common, but it's important to talk about because missing it could affect fertility.
With testicular torsion, there are often outward signs of injury to the testicle, but knowing about ovarian or fallopian tube ischemia is hard. I wonder how many of these cases we might be missing.
I'm afraid it might be a lot. Our next guest, Dr. Barrie Rich, had the same question, and that is why she is the first author on a paper, Factors Associated with Delay to Care in Pediatric and Adolescent Adnexal Torsion.
Dr. Rich is a pediatric surgeon and associate professor at Cohen Children's Medical Center, which is part of Northwell Health. Dr. Rich, welcome to the show.
Thank you so much for having me.
You're a pediatric surgeon. What signs and symptoms would make you concerned a patient has adnexal torsion?
So I think what's important to consider is any female patient that comes to the emergency room with lower abdominal pain and emesis is to always consider this in the differential diagnosis. As we will see, it's something that can be easily missed. So keeping it on the forefront of your mind in any female patient that presents to the emergency room with these symptoms is critical.
And what inspired you to do this study? Did you think we might be missing cases?
So I did think we were likely missing cases, and I've seen patients where these cases have been missed. And I was concerned that missing this would have such serious implications. I've been interested in adnexal torsion for many years because of the difficulty in diagnosing this. And a few years ago, I actually completed a study where we were looking at the opposite side of the question. How frequently are we taking these patients to the operating room when they don't have torsion? That number was also quite high. Over 40% of the time, we're taking patients to the operating room when we're suspicious of torsion, and they end up not having torsion. Now, we don't want to miss it, and that number may be acceptable because we don't want to end up not taking them when they have it. Well, that inspired me to want to know, how often are we not taking them to the operating room when they have it? And how often are we missing that diagnosis? So that's what inspired this next question, to understand how frequently is this happening and what can we do to find that balance between not overdoing it, but absolutely not underdoing it.
And before we get to results, I want to look at your methodology. You evaluated something called the Area Deprivation Index, or ADI. Can you describe what that is?
Yes. So the Area Deprivation Index was originally created as an index of socioeconomic deprivation. It was based on 17 measures such as education, employment, housing, poverty, with the most disadvantaged neighborhoods having the highest ADI. It's been validated across a wide range of social, economic, and healthcare applications, and we used it in this study as a proxy for social determinants of health. And we used the patient's home address and use national percentiles to provide a national point of comparison as a marker of socioeconomic deprivation.
All right, now the results. Once you evaluated your data, what did you find about delays in diagnosing adnexal torsion?
So we found that it was actually quite common for delays to happen, and approximately 1/3 of the patients in our cohort of 862 patients had a delay in their diagnosis. So when we looked at it more closely, we found that more severe presenting symptoms, such as emesis and fever, and more typical ultrasound findings, such as peripheralization of ovarian follicles, diminished blood flow to the ovary, or a twisted pedicle, well, those patients were less likely to result in a delay. However, there were still patients with diminished blood flow, peripheralization of follicles, or twisted pedicle that did have a delay.
And how much did ADI factor into these delays?
So we found that ADI really did make a difference. In our multivariable analysis, for every unit increase in ADI, the odds of experiencing a delay in diagnosis increased by 1.3%. We also found that distance from the hospital increased odds of having a delay. But most importantly, what we found is, why does this matter? Well, those that did have a delay were more likely to result in ovarian loss or oophorectomy. 14% versus 7% of patients that had a delay versus didn't have a delay ended up needing to have their ovary removed. And that's a big deal.
Did your study offer up any clues about what we can do to improve timely diagnosis and treatment of adnexal torsion?
So I think having a high level of suspicion in these patients, there are certainly findings of lower abdominal pain, emesis, fever, that we should keep this diagnosis in mind. I think because it's such high stakes, as you mentioned, for missing this, it's a diagnosis that, even though we don't see it that frequently, something that should always be kept in mind in children and adolescent females with lower abdominal pain. Obtaining a pelvic ultrasound is always helpful. There's no radiation involved, and I would continue to have a very low threshold to get an ultrasound in these patients to help assess for adnexal torsion.
Well, that is fantastic advice, and I think all of us want to make sure, especially in light of this study, that we're not missing this diagnosis. Do you have any other tips for us to make sure that we catch these kids in time to intervene?
I think I would have a low threshold to get a consultation from a pediatric surgeon or adolescent gynecologist. We also found that those that did not have early consultations were more likely to be delayed. And so calling your colleagues, having us come down to assess these patients if there's any suspicion at all. I know we'd be happy to see and evaluate these patients in an effort to try to minimize missing this diagnosis and working together.
Well, Dr. Rich, thank you so much for joining us today to talk about this important topic.
Thank you so much for having me today.
To read the article, Factors Associated with Delayed Care in Pediatric and Adolescent Adnexal Torsion, visit our website at aap.org/podcast. At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Well, Joanna, you know that I can't go wrong just imitating you, right? Like, if you did a thing, it was probably pretty cool. So I just finished my 1-week didactic portion of Harvard's Media and Medicine certificate course, right? Which you had done earlier, and you said it is so exciting. It is so inspiring. You meet so many amazing people. You get such good tips on how to be a better communicator and how to tell your story better. And I just got to tell you, once again, and unsurprisingly, you were right.
Oh, I love hearing that, David.
Yeah, wow.
So rarely does my family tell me that.
You want me to talk to Danny? We can have a talk.
But I'll make my say about Danny, just to run that back a little bit, which is that I've been on service and he's just been so great with the kids. We're getting to an age where the kids are doing maybe too much after school stuff. You know, we try to simplify it to just like 2 things max per kid. You know, there's dance and there's swim, and then there's swim, and then there's gymnastics, you know, so I'm really thankful that I have a partner who is so engaged in all our kids' activities and can really be there for them when I can't and I'm in the hospital.
Go, Danny. Well, I would say as the dad, it's so much fun. It's so cool to get to be there. So I'm betting he's having a great time too.
He's the best.
That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on YouTube, Facebook, and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producers and editors are Ann Johnsos and Claire Keating. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll discuss biliary atresia in infants.
We'll talk to the authors of a new clinical report, Dr. Sanjeev Harpavat and Saul Karpin. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.